Welcome, everyone. It's my honor to introduce the Health for the World International Grand Rounds speaker today. Our Grand Round speaker today is Dr. Brink. Dr. Brink is Radiologist in Chief at the Massachusetts General Hospital and Juan Tavares Professor of Radiology at Harvard Medical School. Dr. Brink is a renowned radiologist worldwide. Dr. Brink is Fellow of the Society for Computed Body Tomography and MRI, and Fellow of the American College of Radiology, and also the past President of American Rankin Rate Society. For the ACR, Dr. Brink served as a President from 2018 to 2019. Dr. Brink has received numerous awards. Dr. Brink has received American Rankin Rate Society's Gold Medal and an honorary member of the European Society of Radiology, the Italian Society of Medical Radiology, the American Association of Physicists in Medicine, and the International Organization for Medical Physicists. Personally, I have always respected Dr. Brink for his vast knowledge base, excellent leadership, humility, and kindness. Thanks, Dr. Brink, for doing this for us, and you can start whenever you're ready.
Thank you so much, Dr. Hani. It's a pleasure to be with you all here today. I very much enjoy this particular topic because if we understand the pathways for the spread of disease in the abdomen, it can greatly increase the precision of our reporting and help guide our referring physicians to both the appropriate diagnoses and potential complications from the conditions their patients suffer from. And it can also increase our own joy in reporting because as we can recognize how findings interconnect through these pathways, then the more value we feel in the jobs that we are doing and the service we are providing for our patients. So with that, let me move ahead here. There we go. So when we think about the various pathways by which disease can spread, there are embolic or hematogenous routes, which I will not speak of today, but rather we'll focus on the other three: lymphatic extension or spread through the lymphatics, direct invasion between adjacent structures, and intraperitoneal seeding. Lymphatic extension and direct invasion occurs through the retroperitoneum, but also through the peritoneal ligaments and mesenteries, whereas, of course, intraperitoneal seeding occurs through the peritoneal spaces. But insofar as the retroperitoneum gives rise to the peritoneal ligaments and mesenteries, and in those in turn define the peritoneal spaces, really this talk is all about anatomy. And in this particular session, with 45 minutes committed, I'll be able to get through the first two big areas, the retroperitoneum and the peritoneal ligaments and mesenteries, and perhaps another day we can talk about the peritoneal spaces. But I will begin actually in reverse order and begin with the peritoneal ligaments, and then we'll work our way back to the retroperitoneum. So beginning with the peritoneal ligaments, there are three pairs of ligaments in the upper abdomen that form important pathways or highways of disease. In the right abdomen, we have the gastrohepatic ligament and its free edge, the hepatoduodenal ligament, which together comprise the lesser omentum. In the left abdomen, we have the gastrosplenic ligament and its pair, the splenorenal ligament, which form an important pathway of disease as well. And in the mid-abdomen, we have the gastrocolic ligament and its pair, the transverse mesocolon. So we'll go through all of these and understand more about how they serve as conduits of disease and how important they are to understand both diagnosis and potential complications. Beginning with the gastrohepatic ligament, this joins the lesser curve of the stomach, the entire lesser curvature, to the liver, and inserts from the fissure for the ligamentum venosum to the porta hepatis. An important and somewhat unique feature is that the subperitoneal areolar tissue within the ligament is continuous with the perivascular fibrous capsule within the liver, so-called Glisson capsule, and this forms an actual direct pathway of disease straight into the left lobe of the liver from the gastrohepatic ligament, enabling disease in the stomach to penetrate into the left lobe quite easily. We recognize this ligament as with all the ligaments based on the structures they contain. This ligament contains the left gastric artery, the left gastric vein or coronary vein, and associated lymphatics. And in general, nodes and vessels in this ligament are a bit smaller than elsewhere in the abdomen. We use a threshold of 8 millimeters for nodes in this ligament to be considered abnormal. Diagrammatically, we see the lesser omentum comprised of the gastrohepatic ligament and its free edge, the hepatoduodenal ligament. and that gastroparetic ligament is recognized by the left gastric vessels and associated lymphatics. This Netter diagram nicely shows us the lesser omentum. The thin, fatty portion is the gastrohepatic ligament. The thicker portion is the hepatoduodenal ligament. The probe is passing through the foramen of Winslow or epiploic foramen. As we dissect through the lesser omentum or gastrohepatic ligament, we see the tip of the probe sitting within the lesser sac in precisely the superior recess of the lesser sac, here separated laterally or bounded laterally by the caudate lobe and medially by this ridge, which is containing the proximal left gastric artery, otherwise known as the gastropancreatic pleca. As I mentioned, nodes in the gastrohepatic ligament tend to be a bit smaller than elsewhere in the abdomen, typically less than 8 millimeters is considered normal. Here we can see the left gastric artery in the gastrohepatic ligament, and this lymph node, again, being within the 8 millimeter size threshold. Common pathology within the ligament includes varices as well as nodal metastases, as occurs commonly from stomach and esophageal cancer. Lymphoma, of course, can occur anywhere, but certainly other more distant tumors can metastasize here, whether it be breast or lung. Pancreas also can spread up into the gastrohepatic ligament. Perhaps more important than the nodal metastases we see is the direct spread of tumor that we can recognize coming either from the stomach or the liver, given that the ligament connects the two. Here we see a patient with lymphoma with nodes that are exceeding that 8 millimeter size threshold within the, excuse me, must have hit something there, within the gastrohepatic ligament. And when disease becomes more confluent, here we see disease completely filling in. This is lymphoma completely filling in the gastrohepatic ligament. We see it also extending out into other ligaments we'll discuss shortly. But note the indistinctness with the left lobe of the liver. This is indicative of that continuity of the subperitoneal areolar tissue within the ligament with the perivascular fibrous stroma within the liver, so-called glycan capsule, allowing that direct spread of disease straight into the liver. All right, here's a patient who has a mass centered within the gastrohepatic ligament. We see it involving the stomach laterally and the liver medially. It's difficult to say in a case like this where it's coming from. It could be either be coming from the stomach, such as a gastrointestinal stromal tumor, or possibly from the liver as a hepatoma. In this case, this proved to be a hepatoma, again highlighting that continuity between the infrastructure, if you will, within these two ligaments, connecting the two, as I've discussed. All right, here's a different patient with a large mass in the lesser curvature of the stomach. This is a gastric adenocarcinoma. You can see it spreading out into the gastrohepatic ligament, but we know that it has gone down to involve the free edge of the ligament, the hepatoduodenal ligament, because of a complication that we're seeing. And what is that complication? I'm sorry, we're not in person to answer these questions, but you can answer at home. Effectively, we're seeing biliary dilatation, and means, of course, that we have tied up the bile duct with tumor, meaning that the disease has spread down the gastrohepatic ligament to involve its free edge, the hepatoduodenal ligament. Which brings us to the hepatoduodenal ligament, and this is, again, the free edge of the gastrohepatic ligament. It extends from the flexure between the first and second duodenum to the porta hepatis. It is the thickest ligament in the upper abdomen because of the structures it contains. It contains the common bile duct, the hepatic artery, the portal vein, and associated lymphatics. And as we've seen in that diagram previously, the epiploic foramen or foramen of Winslow is immediately posterior to the hepatoduodenal ligament. And in general, size criteria is not as helpful in this ligament as in other ligaments, particularly nodes at the base of the hepatoduodenal ligament, sometimes called portocaval nodes, can be quite prominent and still normal, as we'll see. So again, diagrammatically, this is the free edge of the lesser omentum, the hepatoduodenal ligament containing the common duct, hepatic artery, and portal vein. This is, I'm embarrassed to say, this is in fact my bile duct from when I wanted to go to the RSNA many decades ago, before we were terribly concerned about radiation. My friends and I all ingested calcium orographing granules to pacify our bile ducts to see, this is the very early days of trying to do CT cholangiography, clearly not recommended. But if there's one thing that I learned from doing this is the plane of the hepatoduodenal ligament, which you can see this is the plane of reformation of this scan, which is showing the bile duct laid out on FOSS. And you can see that it's a very, almost a 45-degree angle, which highlights the plane of the hepatoduodenal ligament connecting the porta hepatis of the liver to the retroperitoneum. This is the pathway by which much disease will spread up and down this ligament from adjacent cancers and other inflammatory conditions. And we'll look at many cases like this, but keep in mind, this is the plane of the ligament, almost a 45-degree angle from porta hepatis to retroperitoneum. As I mentioned, this ligament tends to be rather thick because of all the structures it contains. This is a cadaver that's had a CT image obtained by my friend Dennis Balfe in St. Louis, Missouri. He's injected radiopaque substances into certain things and gas in others, and it just highlights the thickness of the hepatoduodenal ligament containing the common duct, the hepatic artery, and so forth. Here's a patient, a rather ugly scan, and a patient who is having a TIPS procedure. And you can see that contrast is now pooling around the cirrhotic appearing liver and tracking in through Morrison's pouch through the foramen of Winslow to ultimately pool in the superior and inferior recesses of the lesser sac. The whole point being is that that contrast is tracking behind the hepatoduodenal ligament containing the hepatic artery and the portal vein. And so knowing that anatomy, even in an ugly scan such as this, you can understand what's happening when you see that contrast pooling in the lesser sac and how it's getting there through the foramen behind that ligament. All right. As I mentioned, lymph nodes at the base of the hepatoduodenal ligament can be quite prominent and still normal. Up to 2 centimeters in width and 1.5 centimeters in height is considered normal. Oftentimes these are called portocaval nodes, but it's probably more important to remember that they live in this ligament, the hepatoduodenal ligament, as it inserts on the retroperitoneum. This node can be quite prominent, and we can recognize it to have pathology when it has central low attenuation or a more spherical shape, as is evident in this case. Which brings us to this patient, a patient with pancreatic cancer, a very ugly invasive mass in the pancreatic tail, extensive hematogenous metastases. But does anyone see the involved node at the base of the hepatoduodenal ligament? You can see it right here. It's not enlarged by size criteria, but we know it is involved with tumor because of the central low attenuation within it, similar to the primary tumor as well as the metastases. Now the question is, why is it involved by tumor? Is it involved because disease from the primary tumor is spreading into it, or is it disease involved because disease from these hematogenous metastases is spreading down to it as well? And the answer is that either is possible, because disease in these lymphatics in the hepatoduodenal ligament can spread either antegrade down from the liver, antegrade with the flow of lymph from the liver, or retrograde coming up the lymphatics from cancers, adjacent cancers in the pancreas or otherwise. And so again, common malignancies in the hepatoduodenal ligament include lymphadenopathy occurring from antegrade spread down from liver or biliary cancers, or retrograde from disease in nodes around the SMA, as can occur typically in colon and pancreas cancer. And of course, lymphoma can occur here as well as elsewhere. This diagram nicely shows us the lymphatics of the hepatoduodenal ligament interconnecting with lymphatics around the celiac axis and SMA, as well as around the pancreas. And you can see again, disease can spread either antegrade down along the flow of lymphatic fluid from the liver and biliary tree, or retrograde up those lymphatics in the opposite direction. I'm going to show a series of unknown cases, not that this format allows too much interaction, but you can play along at home. And our first case is here, and effectively we see a mass in the sigmoid colon extending out into the mesocolon. There is some stool sitting on top of the mass. Hard to tell the difference between the two, but we do know there's a tumor here extending out into the mesocolon, as you can see. And that's a sigmoid carcinoma, and this is accompanied by hematogenous metastases to the liver with a rather mantle of disease around the SMA. And the question is, how did this disease get there? Is it coming down the lymphatics from these hematogenous metastases, Or could it be coming from the primary tumor, the sigmoid carcinoma? Well, typically that would be uncommon because that should be an inferior mesenteric artery distribution, not a superior distribution. And in fact, you can actually see on these scans the disease starting to come down the hepatoduodenal ligament to result in this mantle of disease around the SMA. It's right here. It's this tongue of tissue coming out into the hepatoduodenal ligament. And thus, when you're looking for disease within the ligament, you're often looking for tumor growing in a sheet-like fashion. You may not see the typical sort of rounded metastases that you might see in certain types of tumors. It may be looking more like disease growing in a more sheet-like fashion. In this case, antegrade spread coming down from these hematogenous metastases in the liver to deposits in lymphadenopathy surrounding the SMA. Here's a patient with a mass in the body of the pancreas. We see proximal pancreatic ductal dilatation, indicative of this adenocarcinoma of the body. It's a rather unremarkable appearing mass on cross-sectional imaging. But what's remarkable is that there's also narrowing of the bile duct in the upper hepatoduodenal ligament with infiltration of the liver. When we first saw this case, wondered, could it be a second tumor, a cholangiocarcinoma, in addition to the pancreatic tumor? But at surgery, this proved to be all metastatic pancreatic carcinoma spreading up the hepatoduodenal ligament and infiltrating the liver. So retrograde spread up the ligament from this pancreatic carcinoma. Let's turn now to the direct spread of adjacent cancers in the hepatoduodenal ligament. These occur quite commonly from gallbladder or biliary cancer, but also from gastric or pancreatic or hepatic cancer, as we've seen. Here's a patient with a mass in the neck and body of the gallbladder with a gallstone. You can see that tumor growing out into the hepatoduodenal ligament. Entering the ligament behind the fatty replaced pancreas, we see tumor here, and as we look more cephalad, we see it spreading up to the porta hepatis with biliary dilatation, and then tumor coming all the way down behind that fatty replaced pancreas to insert on the contrast-filled duodenum. This is disease spreading in a sheet-like fashion up and down the hepatoduodenal ligament from this patient's gallbladder carcinoma. Another patient with gallbladder carcinoma, this one's been resected. We see staples in the gallbladder fossa, now with more rounded metastases in the hepatoduodenal ligament, extending all the way down between the uncinate process and the collapsed second duodenum. This is tumor coming down the hepatoduodenal ligament. And in this case, we see it also all the way up into the porta hepatis. This is nodal metastases spreading all the way up to the porta hepatis, all within the hepatoduodenal ligament from this patient's gallbladder carcinoma. It also gives us a other little added tidbit here. This is some fluid surrounding the caudate lobe in a rather characteristic reverse C-shaped configuration, the letter C in reverse. And we may not have time to get to this later, so I'll just mention it. When you see fluid like this, this is in the superior recess of the Leicester sac, behind the gastrohepatic ligament's insertion into the fissure for ligamentum venosum. Fluid back here in that configuration would be in the Leicester sac behind the lesser omentum, posterior to it. Now here's a second unknown case we can look at, and here's a patient with a large mass involving the head of the pancreas invading the gastric antrum. We see pancreatic ductal dilatation and pancreatic atrophy proximal to the mass, so a rather obvious adenocarcinoma of the pancreas. We see adenopathy out in the hepatoduodenal ligament, so this is a pancreatic carcinoma. And the question is, what complication in the hepatoduodenal ligament are we seeing on this image? And here we see numerous hyperenhancing structures within the pancreatic head and encasement of the portal vein. This is cavernous transformation of the portal vein, perhaps better seen on sonography, where we see those collaterals opening up all within the hepatoduodenal ligament. I only highlight this case because this ligament, because it contains so many structures, we could spend a whole hour talking about all the conditions that you can see in the hepatoduodenal ligament, whether it be complex stone disease, such as Maurizi syndrome, a cavernous transformation from portal venous obstruction, or other conditions that are related to these various structures. Let's turn now to the left side of the abdomen, where we'll look at a similar pair of ligaments, the gastrosplenic ligament and its pair, the splenorenal ligament. The gastrosplenic ligament, unlike the hepatoduodenal ligament, is probably the most thin or filamentous ligament in the upper abdomen. It contains the fundus of the stomach, greater curvature, to the splenic hilum, and you can see it's rather thin and filamentous. If we stick our thumb in this fluid and our finger in this fluid and squeeze, we're holding the gastrosplenic ligament. Our thumb would be where? This would be in the inferior recess of the lesser sac, and our finger would be in the gastrosplenic recess of the greater peritoneal cavity, and thus we would be holding that gastrosplenic ligament. And there it is. All right, so diagrammatically, here is the stomach, here is the gastrosplenic ligament connecting the greater curvature at the fundus to the splenic hilum, and it together with the splenorenal ligament forms the left wall of the lesser sac. The splenorenal ligament contains the pancreatic tail, splenic artery, and splenic vein. As we've seen, it joins the greater curvature of the stomach and the spleen, continuous with the gastrocolic ligament medially, and we'll come to that in a few moments. We recognize all these ligaments by the structures they contain, and this one contains the left gastropaploic and short gastric vessels. Common pathology involves gastric disease that can spread to the spleen, and sometimes pancreatic disease that can spread to the stomach, first getting to the spleen via the splenorenal ligament. Here's a patient who has a large mass in the fundus of the stomach. This is a patient with a gastric adenocarcinoma. The patient was lost to follow-up for 6 months and returned with the following scan. You can see that there's been extension of the tumor through the gastrosplenic ligament to the splenic hilum, where the tumor is now infiltrating and dissecting the spleen with tumor. There's been no history of trauma. This is a malignant ulceration into the spleen with dissection of the spleen with tumor, the pathway here being from gastric fundus through the gastrosplenic ligament to the splenic hilum. The spleen tends to be a rather forgiving organ. When disease gets to its hilum, it often penetrates right in, and we'll see that occurring in other cases as well. Pancreatitis is very commonly involves the gastrosplenic and splenorenal ligaments. We often call these fluid collections peripancreatic fluid collections, but I encourage you to be thoughtful about where they exist. Almost always these are subperitoneal collections, opening up potential spaces within adjacent ligaments and mesenteries, and this one is no different, opening up a potential space in the gastrosplenic ligament. And you know these to be subperitoneal because they're the same day after day, week after week. They don't change because they're really confined within the subperitoneum. Here's a patient with an unusual situation that I must say we don't see as often anymore. Earlier in my career, we would see this typically about once every 6 months, and I'd be eager, any of you who might wish to share with me how often you might see a case like this, I'd be eager to hear from you. This is a large hematoma in the gastrosplenic ligament resulting from ulcer disease, and in fact, the ulcer may actually be right here coming off the posterior wall of the stomach, resulting in this large hematoma in the gastrosplenic ligament. And you can see it actually extending over immediately into the right abdomen in the probably gastrohepatic and hepatoduodenal ligaments as well. Interestingly, the gastrocolic ligament is here between stomach and colon, and you see some of the hematoma extending that direction. The surgeons decided to drain this ligament, this hematoma in the gastrosplenic ligament, so they put this large bore drainage catheter into the hematoma, and you can see they nicely drained it. But what they didn't think about was that the ligament directs the tube right to the splenic hilum, and with a little too much force, they've pushed the tube right through the spleen. Again, remember, not thinking about the fact that that ligament will guide the tube to the splenic hilum, the spleen being a very forgiving organ, split right in two as they advance the tube. And again, highlighting where this hematoma is located. As an added feature, we also see some liquefying hematoma over here. This is anterior to the gastrohepatic ligament being bowed posteriorly. You see the left gastric artery within it. And so this is in the greater peritoneal cavity, in the gastrohepatic recess of the greater peritoneal cavity, ventral to the caudate lobe, and thus not in the lesser sac, because it's pushing that lesser omentum posteriorly rather than anteriorly. All right, case number 3 is here. We see confluent soft tissue in the gastrosplenic ligament. And we see, I guess I've given it away, this is gastric lymphoma. It's encasing but not obstructing the splenic vasculature. And as we see that disease turning toward the splenorenal ligament, we see the encased but not obstructed splenic vein, the splenic artery, as is common with lymphoma. The splenorenal ligament, again, forms with its pair, the left wall of the lesser sac with the gastrosplenic ligament. It contains the pancreatic tail, proximal splenic artery, and splenic vein. You can see we've covered most of this already, forms left wall of lesser sac. The disease here is mostly about the pancreas, disease spreading to the splenic hilum from the pancreatic tail, whether it be benign or a malignant disease. Here's a patient with a large mass in the pancreatic tail spreading through the splenorenal ligament to involve the lower pole of the spleen, all held together by the splenorenal ligament. This is an acinar cell carcinoma of the pancreas. Here's a patient with intrasplenic pseudocyst having gotten to the splenic hilum via the splenorenal ligament. This one has gone on to then turn and form a larger pseudocyst in the gastrosplenic ligament, again highlighting that continuity between the two ligaments. Again, the pathway here is from pancreatic tail to spleen, into the spleen with intrasplenic pseudocyst, and then a large pseudocyst opening up in the gastrosplenic ligament. Here's another patient from some time ago. This was a patient who also has bad pancreatitis and several fluid collections, but you can see dissection of the spleen. This patient actually fell out of bed, making it somewhat curious as to what the problem was, but there's no obvious evidence of acute blood, and so this proved to be intrasplenic pseudocyst when they debrided the pancreas, but it was a bit confusing given the history of trauma. All right, this patient has obvious varices in the gastrosplenic ligament and splenorenal ligaments. You can see them opening up, including varices that are extending now anteriorly toward the gastrocolic ligament. The patient has hyper-enhancing metastases in the liver, and anyone care to offer diagnosis in your homes or wherever you happen to be? This, in fact, is metastatic islet cell tumor coming from the pancreatic tail, and one might guess that because of these varices, when in fact, the little lower down, in fact, we do see the primary tumor because it's obstructing the splenic vein, and we're really witnessing the collateral flow around an obstructed splenic vein through the short gastric and gastroepiploic varices that open up in the splenorenal, gastrosplenic, and gastrocolic ligaments, ultimately forming the gastrocolic trunk, which drains into the superior mesenteric vein. There's the collateral circuit complete all the way around into the gastrocolic trunk. All right. And that takes us now to the midline, where we'll look at the gastrocolic ligament and its pair, the transverse mesocolon. The gastrocolic ligament, also known as the greater omentum, sometimes called the abdominal policeman, because the free portion of the omentum can wall off inflammatory processes when untreated within the abdomen. It does join the greater curvature of the stomach to the transverse colon. On the left, it's continuous with the gastrosplenic ligament. We saw that in the hematoma case, which had continuity between gastrosplenic and gastrocolic ligament. We've just seen it in the collaterals case, where we've seen the short gastrics communicating with the gastroepiploics from the gastrosplenic ligament to the gastrocolic ligament. And an interesting feature is the gastrocolic ligament is formed by 4 layers of peritoneum that invest the stomach. It does contain the gastroepiploic vessels, as we've just witnessed. This diagram, although somewhat crude, shows us a sagittal representation of the stomach, labeled G for gastrum. The gastrocolic ligament connects the stomach to the transverse colon and then continues on as the greater omentum below the transverse colon. And here is the transverse mesocolon coming back to the pancreas and duodenum. And these are particularly thick, the greater omentum and the transverse mesocolon, because embryologically these form from fusion of multiple layers. And thus there's a potential space within the transverse mesocolon that opens up quite easily under pressure from the retroperitoneum, and we'll see this. You see this all the time in your practice, but may not think about it. I should also mention RPS stands for right peritoneal space, because that is the lesser sac. This is the lesser sac here. All right, so here's what some might call a pre-pancreatic fluid collection, just ventral to pancreatitis. But I submit to you this is actually opening up the potential space in the transverse mesocolon as I've just mentioned. Now, the gastrocolic ligament is a very common site of pathology in the setting of peritoneal carcinomatosis. The big four tumors that do this are, of course, ovary, stomach, colon, and pancreas. It's also a common site of disease for the direct spread of disease from stomach to transverse colon and transverse colon to stomach. All right, so certainly carcinomatosis is well known to you. You see this quite commonly in your practices. It can have a very cake-like appearance, infiltrating the greater omentum, as in this case, or a more marbled appearance, as in this patient, infiltrating the greater omentum. Also seen with thickening and foreshortening of the small bowel mesenteric folds from carcinomatosis. We see thickening of the parietal peritoneum with cutoff of the right paracolic gutter by a malignant adhesion, all from carcinomatosis. The greater omentum can also do some unusual things. Anyone care to offer a diagnosis in this patient with a acute epigastric pain? We see a rather swirled appearance here of the fat within the greater omentum. This is omental torsion. It's said that the right leaf of the omentum torses more commonly than the left, but in this case, I believe it's the entire omentum that's torsed, given the size and central location of this finding. Another, or perhaps of some academic interest, but important to remember, is that the gastrocolic ligament connects the stomach to the upper margin, the superior margin of the transverse colon, whereas the mesocolon coming from the pancreas connects to the inferior margin of the colon. And this is perhaps of some academic interest, but I always find it helpful to at least remember this. It may not be terribly practical, but just remember the diagram as you're thinking through cases. It might help you even in a plain film like this. This is a patient, I'm grinning because it's probably more than one could ever get from a plain film, but suffice it to say that if you knew the history was an adenocarcinoma of the gastric antrum, you might say, well, gee, I see an apple core lesion of the gastric antrum, increased separation between colon and stomach with proximal dilatation and distal collapse of the transverse colon. This is potentially spread of disease from the stomach to the colon via the gastrocolic ligament. That would be a bit of quite a home run from a plain film like this, but in fact, that's what the CT showed. The CT is such a poor quality, I decided not to show it to support it, but suffice it to say that was in fact what was happening. Brings us to this next case, case 5. Again, thinking about this anatomy can be quite helpful. This is a rather ugly scan, no IB contrast, just oral contrast. But I give big credit to the chief of ER radiology at the Yale University, where I used to work, Jamal Bukhari, did a terrific job with this case in spite of great image quality, where he basically said, you know, there's very marked thickening of the back wall of the stomach. There's also thickening of this viscus, which he traced out to conclude was the transverse colon. And he even then said, you know, I see a connection between the two right here. And in fact, his differential at the top of his differential diagnosis was cancer, either of stomach or colon. He couldn't say which way, spreading bidirectionally through the gastrocolic ligament, and he was completely correct. It was a cancer of the colon spreading to the stomach. We often see inflammatory disease causing trouble up here as well, and I have to move my zoom to be able to point here. There we go. You can see, I guess arrows are on it. You can see inflammatory infiltration of the greater omentum. And in fact, we can see a little lower down, in fact, the offending ulcer coming off the back wall of the stomach with bubbles of gas and contrast percolating out into the greater omentum. And when that kind of a disease progresses, that can go on to actually connect to the colon and result in a fistula. This is a different patient, mind you, but benign disease, gastric ulcer disease, can connect from stomach to colon via the gastrocolic ligament to ultimately result in a fistulous connection, as evidenced by this barium enema, where we're filling the colon, but then filling the stomach and small bowel before we've anywhere gotten through the ileocecal valve, and this is coming through that fistula between the two. All right, I'm going to skip all these words and just highlight for you diagrammatically. Probably the most valuable diagram in the talk that I enjoy the most is this diagram, which really highlights the lymphatic drainage of the stomach through the ligaments we've already discussed. It can be extremely helpful to think in these terms as you're looking at disease in the upper abdomen, because it can draw your attention to where disease may be coming from or where it may be spreading. So it turns out that the entire lesser curvature of the stomach drains medially through the gastrohepatic ligament down to its free edge, the hepatoduodenal ligament, Remember the plane of my bile duct, that 45-degree angle draining down to the retroperitoneum to deposit in nodes around the superior mesenteric artery and celiac axis. We can also see disease in the greater curvature of the stomach, superior third, draining laterally through the gastrosplenic ligament to the splenic hilum, and then back through the splenorenal ligament to deposit in those same nodes. Disease in the inferior two-thirds of the greater curvature drains inferiorly and slightly anteriorly via the gastrocolic ligament to the transverse colon, where it turns and then goes posteriorly through the transverse mesocolon, we'll discuss in a moment, to ultimately deposit in those same nodes. And so knowing where disease is in the stomach can train your eye to look for spread where you expect to find it, or vice versa, if you find disease in these areas, to look back and see if you find pathology in the stomach that might explain it. Knowing that anatomy can be helpful in a case like this is case number 6. It's a patient with a mass, a very ugly scan mass, circumferential mass in the antrum of the stomach. And of course, when it's circumferential, we might expect to see it spreading into the porta hepatis via the gastrohepatic ligament, and suffice it to say, we do see disease out in the porta hepatis. But we can also think about where else it might go. And again, if it's spreading immediately through the gastrohepatic ligament to the porta, where else might it go? It's circumferential. And that diagram told us, of course, it could be draining through the gastrocolic ligament. And does anyone see the disease in the gastrocolic ligament? I must say I overlooked it initially, and it was only after I refocused my attention did I see this disease, this large node, plastered up against the anterior wall of the abdomen, inferior to the mass, again, in the plane of where we would expect the gastrocolic ligament to be. So useful to be thinking in those terms as you're reading pathology in the upper abdomen. Let's turn now to the transverse mesocolon. This is the last ligament of this pair. And the transverse mesocolon links bare areas in the pancreas to the transverse colon, spleen, and small bowel. On the right, it's continuous with the duodenal colic ligament. In the middle, with the small bowel mesentery. And on the left, with the phrenical colic ligament and splenorenal ligaments. We've already talked about the splenorenal ligament. Phrenical colic ligament suspends the left colon from the body wall, and we'll see at least its root in just a moment. It contains the middle colic vessels and associated lymphatics. On CT, we identify the mesocolon as the fatty plane just ventral to the uncinate process, and it's important to remember that it may not be completely lined up perpendicular to the uncinate. You may have to extrapolate visually from transverse colon to the uncinate and know that that is the plane of the transverse mesocolon. The root of the mesocolon is here, cutting across the pancreas completely. On the right, on the left, I should say, it extends to the splenorenal ligament. Just remember, the gastrosplenic ligament was continuous with gastrocolic ligament anteriorly, and posteriorly, splenorenal ligament, its pair, is continuous with transverse mesocolon, the pair of the gastrocolic ligament. We also see it connecting to the phrenical colic ligament, which suspends the left colon from the body wall. In the midline, we see the root of the small bowel mesentery coming in. You can see that all the small bowel mesentery comes down to this root that is probably 8 to 12 inches in length from the mid portion of the transverse mesocolic root down to the ileocecal valve. And one more added feature here is this portion of the transverse mesocolic root, which is what's called the duodenal colic ligament. It connects to the right colon and across the duodenum to this transverse mesocolon. A very important feature of this portion of the transverse mesocolon is it contains the lymphatics that are draining the right colon. And this explains why a cancer of the right colon can result in gastric outlet obstruction or obstruction of the duodenum, because lymphatics draining up along the right colon can deposit in nodes around the duodenum owing to the fact that those lymphatics come across this duodenal colic ligament. All right, so transverse mesocolon, common pathology often is about the pancreas, pancreatic cancer or pancreatic inflammatory disease extending out into the mesocolon, or in some cases penetrating through it. And this unusual feature of cancers of the right colon that can spread up the lymphatics in the right colonic mesentery across the lymphatics of the duodenum to deposit in nodes around the duodenum and pancreas. Here's a patient who's had a history of trauma some time ago, about a week previous, and you can see the patient returns now with early satiety, meaning feeling full from eating. The upper GI shows inferior displacement of the fourth portion of the duodenum, spiculation of the fourth duodenal folds. We see enlargement of the papilla ovata here. This is so-called Poppel sign, indicative typically of a pancreatic problem. And we see marked mass effect on the back wall of the stomach on this lateral view. And it shouldn't surprise us that on CT we see that there's been a complete transection of the pancreas with a large fluid collection that has dissected open the transverse mesocolon ventral to the pancreas and is extending to the splenorenal and gastrosplenic ligaments laterally. Again, we might in other times call this just a pre-pancreatic fluid collection, but again, I encourage you to think about where that is opening up that same potential space we looked at earlier within the transverse mesocolon. These fluid collections are typically subperitoneal, and that enables them to connect to other subperitoneal locations such as splenorenal and gastrosplenic ligaments. All right. As I've shown diagrammatically, the mesocolon connects the pancreas to the transverse colon, typically along its inferior border. And again, remembering that can be helpful in a case like this. This is a patient in whom we see it's a patient with a cancer of the pancreas, but we have this process extending to the transverse colon through the transverse mesocolon. And we can see that this modeled gas collection looks like stool. And it's no surprise then, knowing that anatomy of the mesocolon connecting transverse colon to pancreas, it's not hard for us to presume that this is a malignant fistula to the transverse colon from the primary tumor, with stool coming back through the fistulous tract. And again, remembering that anatomy can be quite helpful in cases like this. One more case, here's a patient who has a mass in the body of the pancreas. Question is this resectable or not? I actually told the surgeons I thought it was resectable. And when the surgeon called me from the operating room to say that after he opened the abdomen and lifted up the transverse colon, he saw the tumor growing through the transverse mesocolon to invade the jejunum. And does anyone see where I missed it? There it is right there. You can see that tongue of tissue going from the primary tumor to invade the jejunum. And again, just knowing the anatomy, that has to be penetrating through the mesocolon to get from the retroperitoneum to that inframesocolic compartment where the jejunum lives. So this proved to be unresectable pancreatic carcinoma. Let's look very quickly in the last few minutes at this unique feature about cancers of the right colon spreading across the lymphatics of the duodenocolic ligament. Here's a mass involving the cecum. And does anyone see the disease within the lymph nodes centered within inside the duodenal sweep? You can see it, there's the primary tumor, and that node with tumor in it is highlighted because of the central low attenuation within it. This is inside the C-sweep of the duodenum, again, having reached that location via the lymphatics of the duodenocolic ligament. And there's another patient with a right colon cancer that's been resected now with this patient with larger low attenuation nodes, also having reached this location via the duodenocolic ligament with stippled calcification, and again, highlighting that continuity with lymphatics of the right colon, potentially resulting in gastric outlet obstruction. And this final case shows us a mass in the hepatic flexure. This is a cancer of the colon, extending directly through the right edge of the transverse mesocolon. This is the duodenocolic ligament to invade the second duodenum. And we see that very nicely on these images. And so, in summary, I think we've managed to just get through these ligaments in the upper abdomen in our 45 minutes, but just to review, we've looked at 3 pairs of ligaments in the upper abdomen. On the right, we've seen the lesser omentum comprised of the gastrohepatic ligament, containing the proximal left gastric artery, and its free edge, the hepatoduodenal ligament, containing the hepatic artery, portal vein, and common bile duct. We've seen the foramen of Winslow immediately behind the lesser omentum, the free edge, the hepatoduodenal ligament, giving access from Morrison's pouch or the hepatorenal fossa into the superior recess of the lesser sac. In the left abdomen, we've seen the gastrosplenic ligament connecting the greater curve of the stomach to the splenic hilum, and then on back to the retroperitoneum via the splenorenal ligament, encasing the pancreatic tail and the splenic vasculature, forming the left wall of the lesser sac. And in the midline, we've seen the gastrocolic ligament connecting the greater curvature of the stomach to the transverse colon, and then on back to the retroperitoneum via the transverse mesocolon, and recognizing that very broad connection of the transverse mesocolon all the way across the mid-abdomen from splenorenal ligament to its free edge, the duodenal colic ligament, and connecting with the small bowel mesentery in the midline. So with that, I will stop there and be happy to take any questions or comments.
Thank you so much, Dr. Brink. This was an excellent talk. This was very informative. In fact, I learned a lot too, and I haven't been in touch with abdomen radiology, so this was very good. So we have some questions and comments here. I'll just start from the bottom here. Dr. Enrique Menero from Mexico says, excellent lecture and congratulations, Dr. Brink. Dr. Joseph Musabiyama from Rwanda. I know Dr. Rossman is teaching in Rwanda, Joseph is a second-year radiology resident, says thank you. Dr. Sabuni from Zambia, this is the first radiology residency there, says thank you. Then we have a question here from Brazil. We see internal hernias crossing through ligaments and peritoneal reflections casually. Could you give us any tips to find them more easily? Thank you.
Yeah, thank you. And I'm sorry, the time didn't allow, perhaps in another time, if Dr. Hani would invite me back, I could cover the retroperitoneum and the peritoneal cavity, because that takes just about as much time. I do typically cover some internal hernias, but maybe in a very cursory sense, I could say that, what you're really looking for is loops of bowel that are not where you expect them to be. And if you see a cluster of bowel that does not look like it normally does in all the other patients you look at, that it's loculated or seems like there's a wall around it, or it's in a sac of some kind, this is often a tip that you're dealing with an internal hernia. And but I'd be very happy to go on at some length about this in another time.
Thank you, Dr. Brink. Really appreciate that. Then we have Dr. Ernesto Espinoza, who says, excellent conferences, congratulations, from Mexico. Dr. Williams from Ghana says, excellent presentation, thank you. Dr. Vikas Shah from UK says, this was a fantastic lecture by Dr. Brink. Thank you for sharing your expertise. Dr. Aditi Chaurasia from India says, awesome lecture, Dr. Brink, great pictorial anatomy pictures in addition to radiological imaging. Thank you so much. Dr. Aditi Chaurasia from All India Institute of Medical Sciences, India. Dr. Malik from Kenya says, thank you. Dr. Praveen Kumar has a question from India. He says, how to differentiate infectious peritonitis from peritoneal carcinomatosis?
It's a great question. And I think the carcinomatosis will often result, well, let me begin by saying if you see more cake-like masses or obvious masses within the peritoneum, then that's much more indicative of a neoplasm that's growing and forming tumor bulk. Infectious peritonitis will typically give you more of an inflammatory appearance, which won't give you that bulky degree of tumor. It can be otherwise rather challenging to tell the difference. If you're only dealing with the thickening of the parietal or visceral peritoneum, that can be challenging. And while I would love to say that contrast material can help us, of course, both can enhance. Inflammatory disease can enhance, malignant disease can enhance, and thus one often needs to rely on the clinical scenario to help make the differentiation. Sometimes a Indian labeled white cell study can help confirm infectious disease in the abdomen as compared to malignant disease.
Thank you so much, Dr. Brink. Now we have a question from Patricia Rodriguez Nava. In your experience, what is the RM value for detecting of ligaments dissemination metastasis in the hepatogastric cancer?
I'm sorry, I'm trying to think of what RM stands for. Does anyone, could you help me?
Actually, I'm not sure either. Patricia, you can maybe type in what RM stands for. I'm not sure of that also.
I'm happy to go ahead and speak to it, just in terms, we'll just presume value in general. But so I think that the real value in tumors coming from the liver or the stomach and detecting that spread of disease in the ligaments clearly is local spread of disease outside of beyond the, and I think certainly for guiding surgical planning, being able to inform surgeons before they operate that you expect the disease to be extending down the less momentum or down, particularly if it extends all the way to the end point, which would be the retroperitoneum. This, I think, would be very valuable information to know how to go about approaching those surgical margins, or even if it's a surgical candidate. That would be, I think, very important information because certainly the spread of disease well beyond the organ of origin can sometimes result in a very poor outcome if curative therapy, curative surgery is pursued, but not possible owing to the pre-existing spread.
Right. Thank you so much, Dr. Brink. And we have lots of thank yous. I'll just read out one or two from here. So we have Dr. Cleenam Satiety, who is the chair of radiology at Kollibu Teaching Hospital in Ghana and leads our radiology chapter. All the residents are here today. And Dr. Cleenam Satiety says, great presentation, we learned a lot. Dr. Rohit Srivastava says, thank you, sir. Great lecture and beautifully explained. Rafi Oriflin says, amazing lecture, very informative, and excited to use these lessons for future cases. We also have thank you from South Africa from Dr. Zikala. So I think, let me just make sure we didn't miss any questions. I think we covered the questions. So thank you so much, Dr. Brink. We really appreciate that.
Pleasure.
You know, as the classroom education has stopped in many parts of the world during COVID-19, you can understand your lecture has had such a big impact. So we really, really appreciate this.
My pleasure. Thank you so much, Dr. Hani, and thank you all.
Thank you so much, Dr. Brink. Really, really appreciate this. And thank you everyone for joining today. We'll see you next time. Stay safe and stay well. Thank you. Thank you.
It was a pleasure to meet you, Dr. Brink.
Thank you. Thank you, Jose. Thanks for joining and helping us. Thank you.